Dear colleagues, hello to Santiago and welcome to my presentation on the key elements of psychodynamic psychotherapy of depression. I'm Henning Schauenburg from the University Hospital of Heidelberg in Germany. I was the deputy head of the Department for Psychosomatics until my retirement this summer. And to mention for this talk, I am a member of the steering group of the German National Guidelines for the treatment of unipolar depression since 2008. So I am glad that you are here and are listening to my presentation, and I'm looking forward to discuss this presentation with you on your conference in a live stream afterwards. Here, a short overview. I first will talk about some, in my opinion, key issues of contemporary depression therapy. I will present the German guidelines to you very shortly. And then I will talk about the evidence for psychodynamic therapy, but the main part of my talk will be about key therapeutic aspects in psychodynamic psychotherapy of depression. Yeah, central issues. Of course, there's a long tradition in psychotherapy of depression, starting at the end of the 19th century with Sigmund Freud, and probably starting 2000 years ago with people who tried to help their patients in their depression and not having the means of pharmacology. We still have a high and stable prevalence of depression in any society, and we also have a high percentage of chronic courses of depression. So this accumulation of chronically depressed patients is a severe problem of our mental health system and of our societies. What we also can watch is that we have an enormous increase in expenditures for treatment over the last 20 to 30 years without any measurable success in, for example, lower prevalence or lower amount of chronic and therapy resistant treatment courses. And on the other hand, we have a huge amount of studies on the treatment of the psychotherapeutic treatment of depressed patients, but it's mostly short-term studies. So it's not more than 20 sessions, 16 sessions, and so on. So this is not what we see in our daily practice. Of course, we also see patients for whom this amount of therapy is quite enough, but as you all know, the patients we are worried about are other patients. On the other hand, I will talk a little bit about the impression that we have a little bit better remission rates than the average, or not just a little bit, but better remission rates in chronic treatment-resistant depressives through long-term psychodynamic psychotherapy. So my main issue is that we all need good concepts, institutional concepts for the high-risk group of chronically and therapy-resistant depressed patients. Some words about the German guideline, which originally was a consensus guideline and later on developed to an evidence-based guideline. And as you may know from the English or British guideline, NICE guideline, also in Germany we decided to no longer recommend antidepressants as a first-line treatment in mild depression, but we recommend low threshold psychosocial interventions of any kind and psychotherapy. For moderate depression, as you all know, we have a comparable effect sizes for pharmacotherapy and psychotherapy. And We know that antidepressants show, in the average, a faster onset but less sustainability, even after several months of relapse prevention. And also, we all know about the low adherence. It's almost 50% of the patients who just stop taking their medication. And one important step was that it's mandatory, so to speak, or a strong recommendation that in severe depression you have to have a combined treatment if necessary, so no pharmacotherapy without psychotherapy. And in case a psychotherapy is not working in severely depressed patients, you have to add pharmacotherapy. We have no differential indication for any antidepressant, and research data show that this is just right, because we don't have any differential effects in antidepressants at the moment. The only reason you choose sedative antidepressants like mirtazapine or tricyclics is, of course, if you have a severe unrest or sleeplessness. No specific recommendations in Germany for any psychotherapeutic method. All the schools and psychotherapies which are offered by the statutory insurance system in Germany, which is mostly cognitive behavioral, psychodynamic and psychoanalytic, and since this year systemic therapy, all are recommended equally. Of course, there are quite a lot of publications on the evidence for psychodynamic psychotherapy. I decided to show you the last, one of the last publications of the very important group of Pim Kuipers from Amsterdam. He's probably the most important person in the world on the evidence of psychotherapy in general on depression. And he shows that you all know about this tradition to say that cognitive behavior therapy is has much better evidence than psychodynamic psychotherapy. This obviously was true until 10 years ago, 15 years ago, because we had a lot more, factor 10 times more cognitive behavior studies than psychodynamic studies. This has changed, and if you take into account those studies which show the lowest risk of bias, and this was what Pim Kuipers and his group did, you see, as you can see here, marked in yellow, that CBT and psychodynamic therapy have equal effectiveness in psychodynamic in depressed patients. But you also can see that BAT, behavioral activation, is probably even more effective in general in these typical short-term studies than the classic psychotherapeutic schools. There's a lot to be said about the relationship between pharmaca and psychotherapy. I just want to show you this graph. Of course, you all know you can show everything with every graph you want to take. So take this into account when I tell you that this in this South American study, you can see an effect which is quite typical in my impression, having seen a lot of depressed patients in my professional life, that here you see two arms of the treatment which approach the healthy range of the Beck depression score, which is below 13, while another arm is, after a good effect in the first 6 months, is staying in the sick range, so to speak, which is the monotherapy with antidepressants. And every time you add psychotherapy, or you have psychotherapy as a monotherapy, you just keep on improving. The patients keep on improving while the therapy is going on, but also after therapy, which is well known. Okay, some words now about the psychodynamic theory. You need to have an impression, an idea of what is the theory behind the treatment. Otherwise, it's almost impossible to understand why therapists in this method act like they act. Of course, we all have the opinion and the impression that depression in later life is connected to childhood or adolescence adversities of any kind. It's early loss, deprivation, trauma, violence, and devaluation, which lead to experiences of abandonment and emptiness in the children or adolescents, and you find certain ways of dealing with these terrible feelings, like an excessive need for external reinforcement, or trying to repress aggressive or negative affects. You also find narcissistic compensations, like unconscious or hidden ideas of grandeur, and also you find this typical obsessive, rigid conscience, and the tendency for remorse. All this leads and prolongs, so to speak, the fragile self-esteem, what we call in the German literature, we call this the basic depressive conflict, which is quite equivalent to the concept and the big five factor of neuroticism. And to deal with this, you typically in the literature, in the psychodynamic, but also partly in the cognitive behavioral literature, you find these two strategies of dealing with this inner neurotic tension, so to speak, which is also on the one side an interpersonal strategy. The patients show clinging behavior, dependency, a strong neediness, and on the other hand, other patients, and of course you find also mixtures, concentrate on their inner ideals and tend to show self-criticism and critical perfectionism as traits which have much to do with their vulnerability to get depressed in stressful life situations. I have to tell you that I come from, or at least are much involved in clinical attachment research. So for me, and also in my clinical experience, it makes perfect sense and helps to understand certain depressive behaviors if you see depression as a security behavior in the sense of Bowlby's attachment theory, however with side effects, so to speak. So security is reached via avoidance of new, possibly disturbing situations, the withdrawal behavior of depressed patients. Also, you find security through attachment to others. You are asking for help, you're calling for help, and also you show sometimes patients show a typical behavior which Jerome Frank in the beginning of the 50s already conceptualized as help rejecting complaining. You all know patients say, "Yes, doctor, but," and then you very fast start feeling helpless, like the patient. So this is a kind of securing your attachment and the closeness to the therapist. And of course, you try to feel secure via orientation along perfectionistic, sometimes but not always, parental standards. And of course, this is kind of preventive self-criticism. You prevent yourself from being devaluated by your environment. So this you have to keep in mind as basic aspects of depressive behavior, which also are responsible for many therapeutic difficulties we encounter in our treatments. talking about the psychodynamic psychotherapy, it is for me being part of this development of the German national guidelines. It's always important to show that treatment of acute depression has some common ground, so to speak, between all therapeutic schools, while the long-term therapy, of course, is quite different between cognitive behavior and psychodynamic therapy. So I will talk firstly about the acute depression treatment. So what do acutely depressed patients need, and what is the psychodynamic stance in these encounters? And some of these things are obviously trivial. We want to be clear and patient. We want to be present and offer continuity, which is enormously important for the acutely depressed patients. Of course, we want to encourage patients and show hope that their terrible feelings somehow will end. And other than in the cognitive behavioral approach, where you find directiveness, you find homework, you find recommendations what to do, you find these things sometimes also in psychodynamic therapy, but more important is to create a therapeutic space where the patient feels understood, of course not left alone, although you might not give homework and might not propose any certain actions, but of course you can do this, but it's more like to understand what is the personality of the patient, what are the things needed, what are the conflicts and problems in the relationships, and doing this. Of course, as a psychodynamic therapist, you have to take into account the personality, so the ego strength, as it was called traditionally, and in our modern language, which is not in Germany, of course, it's influenced by the OPD, by the operationalized psychodynamic diagnostic system, but also in the future you will be influenced, or you can have a look at the new and to be expected way of diagnosing personality disorders with the level of personality functioning scale. And if you have a personality disorder, we need, of course, other therapeutic approaches in psychodynamic therapy than if you have a pure neurotic conflict-related personality or patient. Also, from the view of attachment strategies, it's a big difference if you have a patient who is preoccupied and enmeshed, ambivalent, as Mary Ainsworth called it, or avoidant. Of course, we have to talk in the beginning. We first of all have to talk about motivations and the treatment expectations. Patients will tell you a lot, and you have to ask them about this. And also it's quite important, and this goes along with cognitive behavior strategies, that you have to look for accessible goals in the daily life and for the rearrangement of social contexts if possible. And this comes along with the basic idea that depressed patients have to regain a sense of agency in their daily routine. And also, as a general view in psychodynamic therapy, you have to be aware of this movement from security to exploration, that you start with more supportive interventions and with a stance that tries to strengthen the patient, and also sometimes to strengthen the defense mechanisms of the patient, to regain some kind of control over affects and over daily aspects of life. And then you can slowly, and according to the development of the patient, start with more experiential interpretive interventions, and you can talk about warded off affects. I will talk about pitfalls of this of depression therapies later on. Of course, you have to take into account the necessity of medication especially when you have sleep problems. There's a new study which shows that there's just one differential indication between psychotherapy and medication. If you look at every group of typical depressive symptoms, and that's of course sleep problems. And a typical indication for psychotherapy is concentration problems, interestingly, in this study. And of course, you have to think about medication if the patients experience no relief in the first contacts. So, as I mentioned, pitfalls. Pitfalls, of course, are, which is not so much the danger for us as psychotherapists or psychiatrists, but for general practitioners, for example, that you trivialize the ailment of your patients, that you unempathically try to console them like, well, this will go away for sure, and something like this. And the basic idea is you do these kinds of things because you are under enormous pressure by the patient and by the depression, if you want. So, and you have to take away this pressure to act from yourself as a therapist and from your patient. Also, you should refrain from giving general advices and offering premature solutions. Very famous British analyst coined this sentence, as if one knew how to live one's life. You should be careful with any psychological interpretations, premature interpretations, like talking about confronting with warded off aggression, like why didn't you go into a fight with your husband when he treats you like this, and things like that. Because if these interventions come too early, you probably will damage the self-worth, the feeling of self-worth of the patient, and nothing else. And you also should be careful about, if you have an acutely depressed patient, of course, not to focus too much on negative experiences in the present and in the past. Also, you shouldn't support wishes for changes in the actual living conditions, like splitting with a partner, etc. But you all know about this. And of course, if you become very impatient, you should realize that you are becoming impatient, but you shouldn't act out this impatience, like saying maybe you are not allowed to get better, which is a very complex and inefficient kind of interpretation in my experience. But all of us have used sentences like this, but better not. I will go through this very quickly because of the time, which is unfortunately already running out. We have a publication on the evidence of typical psychodynamic modules of therapy. So all these modules you see here show evidence in randomized controlled studies. And of course, you see certain things I've already talked about, how you prepare a patient for therapy, how you also use education and empowering intervention, also supportive interventions. But the module 5 is, if you want, the core of psychodynamic psychotherapy. So working on inner conflicts and relationship patterns. And also you have to be culturally sensitive, and also in psychodynamic therapy, you have to take into care about certain aspects of relapse prevention at the end. So module 5, I want to talk a little bit more in detail. Has, so to speak, 2 levels. In the first level, you talk about relationship patterns in your daily life, in your relevant relationships, and you can use the axis 2 relationship axis of the OPD. I will show you in the next slide. And here it is. for those of you who are not familiar with this system, you have a matrix where you report the way patients are talking about their relationships, and the upper right shows what the patients are talking about their experience with other people and how they react to this, in a sense, in a kind of defensive reaction. So this is obviously in many cases it's quite trivial because patients are disappointed and react somehow to this disappointment. What is even more important in the axis 2 of the OPD is the lower level, where we can rate our own experience with the patient in two senses: how we experience the patient, him or herself, and what impulses are in us, so to speak, the countertransference, how we react to the patient. The idea is that if this countertransference impulses would be acted out, we would behave like typically important others always, as the patients say, always are reacting or are acting towards me. And in this matrix, which is a kind of circular transactional conditioning, so to speak, of typical patterns, you also find this an aspect which is very important for the psychodynamic therapists in the long course of therapies, working with warded off affects or difficult affects which show themselves in these interaction patterns, especially in the way we are experiencing the behavior of the patient and how we answer to this or want to answer. As professionals, obviously, we do not get angry with our patients or try to treat them as children, but very often we feel these impulses. So then you have a typical OPD relationship pattern which makes it easy to work with. And the levels where you can work with these patterns are on the way of percepting the patterns, so the difference between how patients experience their relationships and how others might experience them. You can talk about complex inner aspects of these relationship behaviors. May they be active or reactive to the environment, and may they be ambivalent or paradox even, and may they show self-fulfilling prophecies. And also you can work on the general aspect of the compromise between wishes and fears in patients, which is an old psychodynamic issue. I won't talk about the control master theory because my time is running out, but for those of you who are interested, I show you the literature here. And of course, which becomes clear through the matrix of the OPD relationship axis, it's also possible, not necessary, if the therapy is running smoothly, it's not necessary to work on transference issues, but if it's difficult and if you have ruptures, as one calls it today in the psychotherapy research community, you have to work on the therapeutic relationship as well. And as you may know, even in cognitive behavior therapy, there's a group, Jim McCulloch and his colleagues, who developed CBASP, and in CBASP you also work on the therapeutic relationship in a more directive way, but at least it takes into account these aspects. Unfortunately, I have to go through this very fast, but it's sort of speaks self-explaining. The main goal of this slide is to show you that, of course, not every depressed patient is like the other, as you all know, and that you're able, and there's a certain tradition to develop a typology of patients. And a typology means they are behaving differently to you as a doctor or as a therapist. You have different goals for the development of personality aspects in them, and you should behave differently. And of course, we all try to adapt our therapeutic interaction to our patients, but this is, especially for beginners, it's quite helpful to realize that these adaptations of our own behavior have some tradition and follow some threads, so to speak, through history of the psychodynamic literature. And just as an explanation or to make this more realistic, I show you some typical issues in depression therapy, like impaired assertiveness, where you try to overcome in therapy, overcome inhibitions, and also you try to help the patient to give up wishes for compensation and to broaden the spectrum of his or her needs. Or you work on the insecurity in interpersonal contacts and also on dependent aspects of the interpersonal relationships. And the slides show just what the basic idea is and the basic therapeutic goals, which come from these typical depression issues. And there are a lot more of these issues, but these are, in my opinion, are the most important ones for the largest group of depressed patients, which are the ones who show the more dependent and more sociotropic, as Aaron Tim Beck called it. So they have to be in good harmony with their social environment and with their social partners, and which brings along a lot of difficulties for the patients, and which is therefore a very important issue of the should be a very important issue of psychotherapy for depressed patients. Of course, the self-critical perfectionism, which is one of the most important negative predictors. Patients with a strong self-critical perfectionism do need more therapy than others, because it takes much more time to overcome this perfectionism and to develop more self-care. And together with this goes the defense mechanism of turning against self, which is also a very difficult mechanism, which is hard to overcome and takes, well, sometimes years or a lifelong trials to do. So to summarize my short presentation, there is a long tradition of psychodynamic psychotherapy for depression, and psychodynamic therapy shows, contrary to what is still today told in public, shows good evidence also versus pharmacotherapy, and it takes into account the complex relation between depressive dispositions, childhood adversities, and personality. We have interventions in psychodynamic psychotherapy which are in themselves evidence-based. We have differential therapeutic stances according to the personality of the patients. And I did not talk about the idea of the duration of psychodynamic therapies, which is an issue of itself. And obviously, and I can tell you from the German experience, the average psychotherapy in the German statutory insurance system, which reimburses this therapy completely for the patients, is about 40 sessions, and 40 sessions in cognitive behavioral and 45 sessions in psychodynamic psychotherapy in the average. And only very few therapies are longer than 60 hours, and it is clear from research in Germany that this is not unnecessary. Patients who stay in therapy urgently need it, and as you know, with these effect sizes in chronically depressed patients, it is perfectly clear that some patients need year-long therapy, but of course not everyone. So thank you for your listening, and I'm looking forward to discuss with you about this presentation.